My name is Monica Lopez. I have the pleasure to serve as committee chair. And I want to tell you a little bit about the rationale for putting together this session. We really were aiming to highlight one of the core tenets of our committee's mission, which is to provide educational opportunities, mentorship, and knowledge sharing for all of AFSA's membership on the fundamental principles of quality improvement, because we know this is what ultimately will drive the needle forward to improve quality and safety of children's surgery care. So our committee does a lot of work throughout the year on several projects, but one that we are really, really proud of is the creation of a comprehensive and highly curated online repository of quality improvement projects and associated materials that is housed online in the Quality and Safety Committee Toolkit. So we know this is a rich resource for all of you, should be accessible to everyone, but we wanted to take it one step further and really understand how effective we are in disseminating some of these QI initiatives locally. That means at your institutions. And so I hope that the content of the session can help us and be valuable to you as you pursue some of these initiatives in your home institutions. I'm going to skip over this for a moment and just tell you a little bit about the format of the session. We plan to have 3 of our fantastic committee members serve as facilitators for some case studies. There's going to be 3 studies highlighting specific pediatric surgery quality initiatives, topics, I should say, as well as unique challenges that are associated in the implementation of these QI work. Then we're going to have the input of our panelists. The content expert panel will then offer some focused teaching on some of these QI implementation concepts, as well as some practical solutions that can be of help in addressing some of these barriers that will be presented during the case scenarios. And finally, we want to engage with you. So we want to have you participate in the discussion. We want this to be as interactive as possible with the constraints of a limited timed session, but I would like to ask you to please take notes and save your comments and questions to the end. So after all the content is presented, then I'll have you guys come up to the mic, or for those who are joining us on live stream, to enter your questions in the chat, and here our chat moderators will get us connected with our panelists to address some of those. In terms of the content of the case studies, I just want to let you know the way that these case studies were designed were to actually address some of the known factors that we know are influential in whether a QI intervention is successful. So you're going to hear a little bit about context. For example, what do we mean by context? So those sets of unique circumstances or factors in which an implementation takes place. So we want to, when we design an intervention, to be able to leverage those those favorable factors for success, and then to overcome those that are unfavorable. And next, we need to talk about strategy. So we need to be able to tailor a specific implementation strategy that will address some of those contextual needs. And finally, we need to know if our implementation was successful. And so you'll hear a little bit from our panelists on what are important implementation outcomes and how these are different from the typical clinical outcomes or service outcomes that we're accustomed to hearing about. So I hope that all of this content is helpful to you so you can actually get an understanding on the general concepts that are applicable to successful QI implementation, and that you can walk away with tangible solutions to some of the common barriers in QI, as well as have an understanding of how to access some of these resources so that you can be successful in your quest for quality improvement locally. So I have the honor of introducing our panel. And so I welcome Dr. Baron Fraser. And he's an assistant professor of clinical pediatrics and emergency medicine at Vanderbilt. He's our cross-disciplinary QI and healthcare innovations guru expert. He's done a lot of training, including the AIM course in Cincinnati Children's. So he will join us today. And next, I want to welcome Dr. Sean Rangel, who's associate professor at Harvard and serves as senior surgical advisor for quality and safety. He's also director of the NISQIP-P antimicrobial stewardship pilot and has served as co-investigator in the Optimizing Perioperative Antibiotics in Children trial. We welcome Dr. Mehul Raval, who's professor and vice chair for quality and safety at Northwestern. He's also a faculty investigator in the Center for Health Services and Outcomes Research at Northwestern. And finally, we're delighted to welcome Dr. Larry Moss, who's the president and CEO of Nemours Children's Health. So with that in mind, I would like to invite my colleague, Dr. Afif Kulaylat, to the podium so he can take us through our first case. Thank you.
Thank you for the opportunity to introduce our first topic. Appendicitis is clearly one of the most common diagnoses we address as pediatric surgeons. And for this reason, small changes in the way we think about or we manage this patient population can have very substantial and far-reaching impact. I will briefly be sharing our institutional context that motivated the specific approach we took to addressing appendicitis radiation stewardship. And I'll be followed by Dr. Fraser, who will share his own institutional experience and really help focus us on a QI implementation lens on how this change happened. There are countless strategies to decrease CT scan use. The majority of them take advantage of some of these key points, whether it is enhancing or improving our ultrasound use, taking advantage of developing clinical guidelines or standardized pathways to reduce variation in care, or using MRI as an alternative imaging source for cross-axial pictures. A number of institutions have shared their experiences with us, and these are readily available on the APSA Quality and Safety Toolkit about the different strategies that they all took within their own institutional contexts. For us, we're a children's hospital housed within a general health system, so that means our children's hospital is adjacent to our adult hospital, and we share a lot of important resources such as the emergency department, operating rooms, and radiology in particular. Our process began back in 2010 when there was emerging epidemiologic literature about the association between increased malignancy risk in those kids who are exposed to higher doses of ionizing radiation, as well as some of the initial reports characterizing MRI use for appendicitis. At that time, we really didn't have dedicated pediatric sonographers. Our coverage was very limited over the weekends and overnight. We were getting pretty inconclusive reads, and many of those kids were getting CT scans or being admitted for observation to help figure out how to sort out their management. Now, because of these shared resources with the adult hospital, and in particular stroke center designations and requirements, we had MRI capabilities that were around, they were fully staffed 24/7, and they were not being used to their full capabilities. And we were very fortunate at that time to have institutional alignment between our departments of radiology, emergency medicine, and surgery in terms of our goals that led us to develop, to adopt MRI as our primary modality for imaging for pediatric appendicitis. In our particular setting, this process change was greatly facilitated by the fact that we were taking advantage of existing infrastructure and leveraging that, so we were using institutional strengths and resources, and we had alignment in terms of institutional support and champions within all of these departments. And overall, the shared learning really that is taking place through these APSA-led quality programs and other quality initiatives throughout the country has greatly enhanced the spotlight on quality improvement. And it's allowed us to compare and benchmark our outcomes with others. And it really has facilitated us working together to implement far-reaching change. So with that, I'll introduce Dr. Fraser.
Thank you again for the invite to come share our story of quality improvement with acute appendicitis. I'll be chatting about how to use the SMART aim to develop context for quality improvement efforts. For those that are new to quality improvement, this man, Dr. Edwards Deming, is essentially the godfather of quality improvement, and his teachings instructed many of the different types of quality improvement infrastructure that we see in Toyota lean management systems, Six Sigma, and the model for improvement. So at Vanderbilt, we use the 3 questions to improvement that is established from the Institute for Healthcare Improvement. And so the first question that we typically will ask is, what are we trying to accomplish? The second is, how will we know that a change is an improvement? And lastly, what changes will we make that will result in an improvement? So when we're trying to answer that first question, what are we trying to accomplish? The model for improvement encourages us to use a SMART aim. A SMART is an acronym that stands for specific, measurable, actionable, relevant, and time-bound. And we'll dive in deeper to these 5 different steps in developing the question, what are we trying to accomplish? So for our quality improvement project at Vanderbilt for reducing CT utilization in suspected appendicitis, the SMART aim helps us determine operational definitions, which is a clear and understandable description of what is to be observed and measured such that different people collecting, using, and interpreting data will do so consistently. And this is incredibly important, especially when bringing different team members with different roles, perspectives, and ideas on how to embark on this change, especially when we have different motivations as well for the change that we want to see in our healthcare system. So when we're thinking about specific for our project, we need to decide what setting do we really want to focus our efforts. How do we define clinical suspicion for suspected appendicitis? What about patients that have underlying conditions that may benefit from additional imaging, as well as those who come from referring hospitals with CT imaging? For measurable, what are the things that matter to us? What are the primary measures? What are the key process indicators or the process measures that will make a difference for our primary measures? And the balancing measures, which are the unintended consequences of change when we implement them into our system. Actionable. So do we have the authority to change our system? And if not, do we need to rethink who's on our quality improvement team to enact these changes? For relevant, is there evidence for this quality improvement work? Is there traditional research that has given us information that we can use to provide decision support, especially the pediatric appendicitis score for our case that allows for us to stratify risk differently based on the patient's clinical presentation as well as their laboratory evaluation? And is the time right for this improvement work? Are there other initiatives that are ongoing in the hospital that would potentially dilute our efforts for reducing suspected appendicitis if the hospital is focused on something else? And do our leaders in the hospital actually support the work that we're doing? Because obviously that is important for us to be successful. And lastly, for time-bound, when do we expect to see these changes enacted? Sometimes we are able to say we want to make changes, but we are unable to provide a certain time frame of when we expect those changes to occur. So when we created our team, we had to think about all the phases that a patient who has suspected appendicitis will see. So our team comprised of surgeons, emergency medicine physicians, a radiologist, and our surgical and medical residents who are integral in the care of these patients. We ultimately developed a SMART aim to reduce CT utilization in the pediatric emergency department for the evaluation of children without underlying GI disease who present with suspected appendicitis from 31% in July 2021 to 15% by June 2023. We identified our primary measure as CT utilization in suspected appendicitis, and our process measures looked at timing and frequency of surgical consultation, as well as the use of a new radiology template utilization. Our balancing measure looked at negative pathology appendectomy rate and ED return visits within 72 hours with an ultimate diagnosis of appendicitis. We used statistical process control charts, which is a type of time series analysis to measure our change, as well as to detect special cause variation. On the y-axis is the percent of which we're using CT for these patients. On the x-axis is time. Our baseline data showed a use of CT about 31% of the time, and there's annotations that show different interventions that we used over time to improve our performance, which included developing a formal clinical practice guideline, order set use, incorporation of a radiology template, and a few other things. And so from our baseline of 31%, we were able to reduce our CT use to 12.5%, which has been sustained for over 10 months. When looking at our process measures, we particularly focused on surgical consultation timing. We had become used to starting to order CTs before surgery was involved, and we were underutilizing our surgery expertise at our hospital to provide additional guidance on whether CT imaging was necessary or if the patient would be able to forego CT imaging. And so we saw an increase in our surgery input before CT use was, our CT was performed from 69% to 94%. And to some of the dismay of some of our surgical residents, we actually didn't see a huge increase in our surgical consultation rate. So there was a brief increase shortly after our order set was utilized, but we didn't see a sustained change, and only about a third of our patients ultimately will have a surgical consultation. We also saw an increase once our radiology template was developed and released from about 20%, and which has been sustained to 80%. The intention behind the radiology template was to provide more information for our end users, so our emergency medicine colleagues as well as our surgery colleagues, on what specifically did the ultrasonographer or our radiologist visualize in more detail, so we can, instead of just saying simply, we did not see the appendix, are there any other secondary findings, and those would be listed for that radiologist to respond to. So ultimately, the lessons learned from our quality improvement project is that it's really important to identify the stakeholders early. This is not just a surgery problem. This is not just an emergency medicine problem. This is a relatively complex multi-care team initiative that really needs buy-in from all these different pieces, especially our residents as well, who are our frontliners. We also needed to be thoughtful about our team and developing those operational definitions to ensure that for all of our team members that we were focused on the primary measure of reducing CT utilization. And using a framework such as the model for improvement is really helpful for quality improvement work, because it provides a guided pathway for us to make sure that our work is measurable and achievable, but also something that we can ultimately display to other people, and for them to also understand and learn from our wins and our losses. Thank you so much.
So shifting gears a little bit, let's look at antimicrobial stewardship now. We've all heard this phrase repeated times, right? But why is it important? As soon as I figure out how to move this. So inappropriate use of antibiotics is associated with increased resistance, increased drug-related adverse events, and healthcare costs increase, right? Antimicrobial stewardship programs have shown that they're going to decrease unnecessary antimicrobial use and improve the quality of patient care. Moreover, for level 1 and 2 CSV centers, they're required to have an antimicrobial and antibiotic stewardship program and demonstrate active initiative pertaining to monitoring, reporting, and education of appropriate antimicrobial use. So just take a look at this question. Just take it in and let it help you ask some questions at the end of this session. But let's start with a case study. Let's say this is me. I'm in a freestanding children's hospital, and we're contemplating the pursuit of ACS-CSV. And as such, we've implemented a surgical PIPS program, a committee. We meet monthly. We have active surgical subspecialty involvement. However, we have only 2 designated quality specialists who have competing institutional demands. As a surgeon champion, I review the NISQIP surgical antibiotic prophylaxis data, and we see that hey, I'm in an outlier status here, right? On the domain of duration of antibiotics for more than 24 hours. So what do, right? I have a lot of questions. What are the initial steps to address this issue? How do I establish an effective team? Given all these competing demands that we all have, should I just build on existing resources? Should I start from scratch? How does one choose the right implementation QI strategy? And for this, I have the honor of having Dr. Rangel, who's going to take us through these questions.
Are kind of through the questions indirectly, maybe. So thanks, Raquel. And again, it's a pleasure to be here, part of this esteemed panel, including Larry Moss, my ex-mentor from about 20 years ago. But I will be talking about reducing postoperative prophylaxis utilization. And I think it's really important to emphasize something that Raquel mentioned, if I can figure out how to advance these slides. And that is that antibiotic stewardship and efforts in a program are now mandatory for being verified as a CSV center. So those of you who are going up for verification, those of you who want to become re-verified, you need to do these things on the first day of the site visit. And so today what I hope to do is not only give you a bit of insight and guidance about how to carry out a QI project or some of the lessons learned for reducing postoperative prophylaxis utilization, but also give you some of the tools to actually become verified as well. And once you become verified, you actually become more powerful in addressing future antibiotic stewardship projects such as this one as well. So why should we focus on prolonged duration? Well, for us it was easy because that's where we needed a lot of help. But there are other potential targets on your report as well, such as use of overly broad spectrum agents and indicated prophylaxis as well. Much of the resources and guidance and insight we'll be talking about today actually has broad applicability across these other number 2 and number 3 as well. So if those are the areas of improvement you need to focus on, again, you can use a lot of what I'm going to be talking about today, particularly in terms of the team building and the collaboration piece. So a little bit of our dirty laundry. So this was our SAP report back in 2022. So this gives us our data for 2021, the entire year. And we were happy to see that we did very well with some of these measures, but for postoperative prophylaxis utilization, clearly we love to give it. And we were outliers for extending prophylaxis greater than 24 hours, and that's what we knew we needed to deal with to get re-verified, which was only going to be a year later. And so this gives you an overview of how we tackled this project in 2022. Each one of these 4 bullets could actually demand a full hour, if not more, of talking about what we did. I think I have about 8.5 minutes left. And so what I wanted to do is really give you the nuts and bolts of the key things that I think made us successful and that you can learn from and take back to your own institutions. The first is really to understand your data and your report and have to drill down on it. And so having the report itself, like I showed you, even when you drill down into specialties, is not enough. You have to go onto the website, and this is something you want to reach out to your SCR or your program manager and really dive into all the resources that are available. It teaches you how to dive into your report at the case and procedure level. It has webinars, digitized PowerPoints that give you a sense of exactly how to dig through your data and package it for dissemination, and really how to package it to prepare for a QI project. I'm not going to go over that because there's a lot of tutorials already on the website, but I really encourage you to dig through that. Now, once you have a really good understanding of your data, it's now time to figure out how do you do strategic outreach and get the stakeholders engaged. And the first thing is really to put together an informational package based on a lot of the resources I just showed you. And again, I'm not going to go over it in detail, but I will tell you when you're on that site and you review the tutorials, it will tell you how to put this together and how to send it out to all the stakeholders across your organization. Now, who are the relevant stakeholders anyway? Well, that's easy. It's anyone who's in that chain of command to give those antibiotics and are people who are interested and willing and have the resources to help you. And so these are some of the usual suspects on the screen here. The PIP surgical departments are, of course, obligatory, and you really want to focus and target on the offenders, right? There's going to be the offenders. We all know who they are across our departments, and you want to reach out to them first before they hear about this project from their chief or the ASP people who are torturing them, right? And you want to give them the chance to talk through this, you let them know what the goals are, and what's really useful too is getting their perspective, not only for why they do what they do, but also what they think is necessary for change. PIPS administration is critical. Your medical director of children's surgery and your program manager, that's obligatory because this has to be part of PIPS. And ASP leadership is critical, right? Your antibiotic stewardship program. That is critical not only because they do this for a living, but also you want to establish a perioperative antimicrobial stewardship team that is truly collaborative. So this is our team, and I love these guys, right? So these are antibiotic stewardship leads, and they couldn't be more excited that a surgeon was anxious, not only enthusiastic, but anxious to partner with them to address some of these issues. Right, we have our hospital pharmacist who is really key in terms of overseeing a lot of the overchange or the order set change and IT things and that sort of thing. So it's great for them because we're available at any time to weigh in on different considerations of perioperative stewardship, and at the same time, they provided a lot of expertise that we don't have. They think about this stuff for a living, and really, it's really has been a very incredible collaboration, not even through this project, but also since we put this together as well. So once you have the engagement, it's time to think about, well, what are the drivers for change? And there are a lot of resources to help you think through this. This is probably the best, most comprehensive resource available, and this is available through the CDC with collaboration from the IHI, but it's a dense document, and it's really hard to get through. It's highly theoretical. It's like whole level stuff, right? And most of us don't understand it. But I say that everyone should have this in their back pocket in terms of preparation. Now, we use this for this project, but I'm actually going to give you a bit of a cheat sheet here. And this is some of our key drivers based on basically what we learned over the past year, as well as a literature review, and a lot of our lessons that we learned from failing over the past year as well. And it really breaks down into two things. The first is a lack of knowledge and awareness on behalf of surgeons. So yeah, there are the issues with lack of knowledge regarding overestimating the benefit of postoperative antibiotics or underestimating the harm. But probably the most compelling lack of knowledge is thinking that everyone does it just like I do. This is probably representing the norm. There's also a profound lack of awareness about what Q8 hours times 3 means in terms of postoperative coverage, because that doesn't start until the pharmacist decides that the dose given in the OR is done. Most of these kids get 30 plus hours of postoperative coverage, and you can roll back on that. And then the second set is really lack of decision support at the time of order entry, right? And that's really relevant to that rogue surgery resident. There's nothing more dangerous than a well-intentioned surgery resident who's putting in orders without any guidance or decision support, right? So beware of them. So those are really the key points to think about for drivers at most of our institutions. So the next thing is to optimize surgeon buy-in. So the first part of this is you have to make sure you reassure them that you're going to track SSI rates. No one is going to back off on their antibiotic utilization unless they know we're going to carefully track SSIs, and this is actually part of the standard NESC workflow anyway, so that's going to be part of the progress reports and PIPs. The second is extremely important, and that is really the educational components that needs to be rolled out with this project. And again, it's important to tell people the age-old story, right, that giving too much antibiotics is harmful and increases resistance. But what is really powerful is the knowledge that what others do is not what I do, and they have just as good of results. And that's why we really emphasize with that package I mentioned earlier, you have to present them the data from the NESQIP pediatric, from the pediatric pilot effort. And so I want to point out Catherine Heath sitting over there, who wrote this paper and led this as our NESQIP SAP scholar. And what she showed is essentially across pediatric hospitals, right, NESQIP pediatric hospitals, there was no correlation between more intensive use of postoperative prophylaxis and SSI rates after adjusting for all the important things like case mix and comorbidity profiles. And what is even more compelling is when you break it down in individual specialty, it's just as bad, right? No one has figured out how to do this well. And this, what you're seeing on the screen here, was the most powerful informational change for my surgical colleagues. Even the spine surgeons saw this and were like, wow, and they became early adopters. And you heard that right, my spine surgeons became early adopters with order set changes, all right? So then once you get people on the same page, again, we're talking surgical attendings. The other big issue to deal with, what happens with these rotating residents, is this was a pain point for us where the PDA cycles really came into play with this insight. And we came up with two strategies to address this. The first is use of standardized closed loop emails for residents when they rotate on the surface. The expectations, where to find the order sets. And the second was well-designed IT solutions at the point of order entry. For us, the most important change was the simple ones, changing the automated orders from Q8 hours times 3 to times 2. Makes a big difference, reduces your post-op utilization by a third. Right, so we're a Cerner center, and it sucks in terms of doing this kind of projects. For you Epic folks out there, there are a lot of other opportunities in terms of building in, decision support specifically at the point of order entry, as well as cross-checking and auditing as well. So really, you should explore this again with your ASP people, because they're the ones with the greatest knowledge. And then finally, this has to be embedded into PIPs. This has to be owned by PIPs. So after the initial rollout, the education and kickoff presentation has to be done at PIPs, and it has to be marquee, the most important thing we're talking about at PIPs today. Regular PIPs updates have to happen in terms of progress and auditing. And again, those ASP folks, the OR pharmacists, the ID folks, they have to be part of PIPs as regular members, and they have to be involved with these efforts. So did we make a dent? Well, I'm happy to say we did, and I was really happy to present this earlier this year with our verification visit. Between 2021 and 2022, we reduced our overall utilization greater than 24 hours by 43%, and we did not see an increase in SSI rates. This is where I was really excited. So when we looked at our spine procedures, this is where we saw the biggest gains, more than a 50% reduction overall in utilization greater than 24 hours and no difference in SSI rates. So you think, wow, well, the SSI rates are double. Well, they're actually not, because there's a lot of fluctuation year to year because the event rates are so infrequent, and typically we see between 1.5% and 3.5%. So there's some final take-home points on the slide. I'm not going to read those out for you, but I will emphasize again that these take-home points were the ones I thought were the most important for our success in 2022, and those points also that I think are probably most generalizable to your institutions no matter what you do. Also, these are probably very generalizable to take home if you want to tackle other stewardship projects as well. So with that, I'll end. And again, thanks for your attention. I think we're going to take questions at the end, right, during the panel. So.
Thanks, everybody. I'm Dan Solomon, and I've got the pleasure of setting the table for two superlative experts. And we're going to be discussing enhanced recovery after surgery. I don't think I have to sell enhanced recovery to surgery to anybody in this room. Every time we look at it, we find that it improves outcomes. Some of those outcomes can be directly converted into dollars and cents, things like length of stay, when trying to make decisions that might have financial ramifications, but others are slightly more subjective, like patient-reported outcomes and pain scores. This wouldn't be a breakout session from the ABSA Quality and Safety Committee if I didn't once again plug our toolkit, which is available on the ABSA website, where we have a multitude of best practices and ERAS protocols. Because we have two experts, I want the audience to think about two different case studies. We'll start with a top-down approach where you are a representative to a multi-institutional quality collaborative that would like to perform a multi-site trial of ERAS protocols. In this sort of situation, the ERAS protocols are being served up on a plate. You have clinical support, you might even have funding. But to be able to successfully implement these protocols, you need to identify and recruit key stakeholders, as well as create enthusiasm among different groups of people. Alternatively, a grassroots example is a PECTA surgeon who identifies ERAS protocols on the Quality and Safety Toolkit and wants to implement them within their own institution. You have energy for miles, and your whole group has equipoise, but you need money. You need money for new equipment, and you need EMR support and analysts. Through that lens, we'll ask questions as our content experts speak, including how does QI context, homegrown versus participation in quality collaboratives, influence how to create a multidisciplinary team? How do we get support for large and small scale projects and from different contexts. And then finally, how do we measure success? And so with that, I'll bring Dr. Raval to the stage.
All right, thank you. And thank you all for attending this session and giving me a chance to share some of our experiences with trying to implement enhanced recovery through the Enrich Us trial. Here's some of my disclosures, including the funding that goes into the trial, for which some of the data I'll be sharing with you. So these are the realities that we live with. In the United States, less than half of children are currently receiving the recommended evidence-based pediatric care that they should. We all talk about wanting to have evidence-based practice, but we don't really have practice-based evidence to inform that practice change. And ultimately, 2/3 of all errors in medicine result from failing to apply knowledge that we already have, right? And ultimately, medical errors are now the 3rd leading cause of death in the United States. So just like you all, I come to these meetings every year and I'm like energized, I'm enthused, I'm ready to go back home and implement so many of the awesome ideas that I've heard. And unfortunately, most of the time, I fail. And the reason I fail is probably because we have heard about what works within a specific context, what works for one site, one hospital, one group of surgeons, but we haven't really thought about it in terms of how it applies in our context and how it can be scaled. And you've all seen this diffusion of innovation curve. It takes 20 years for evidence to get from bench to bedside. And yes, we come to these meetings and we're inspired by innovators and early adopters, but really we know that a lot of these surgical interventions and the data that's coming out of these studies really fails to make it out to the majority of our patients and to our populations. And so that's really where implementation science is, I think, the next frontier beyond the science of quality improvement. And to define it, implementation science is the study and application of methods to integrate evidence-based practice, evidence-based research into your practice. This is a great review article published in JAMA Surgery a few years ago that talks about the cycles of implementation science and how you can see embedded in the box that's on the right side of the screen the PDSA cycles of QI. But really what we need to do more of is focus on pre-implementation, making sure that we've identified the right levers to pull, the right buttons to push, the right projects to throw our weight behind, and then understanding the context, the inner context, the outer context, the stakeholder perspectives, hearing from our patients and their families whether or not they think the interventions we are proposing are a good idea, and understanding the perspectives of the providers on the front lines who are going to be the ones executing that specific quality improvement intervention. And so to me, these are two sides of the same coin. Quality improvement emerged from industry. It's really about systems level work that is meant to improve the quality and safety of care. We really think about performance measures, things like process measures, compliance measures, order set utilization, things along those lines. And that's where all of our energies have been focused to date. But I would actually argue that we need to spend more time thinking about implementation, which evolved from behavioral sciences. And that's where we have theory-based models that really promote the systematic uptake of these evidence-based interventions, as I've already defined. And they really focus on the scientific study and timely uptake of those interventions, things like acceptability, feasibility, and sustainability. So let me give you a practical example of this pipeline. Think about efficacy studies. These are things we understand, right? These are like pilot studies, small tests of change. They prove that the intervention that we're proposing, whether it be enhanced recovery protocols or anything for that matter, are safe, that they're feasible. We do a pretty good job of efficacy studies. We also are wired to think about things in terms of the clinical effectiveness of our interventions. The outcomes we care about as surgeons are absolutely important, and they are things like length of stay, balanced by readmissions perhaps for an enhanced recovery protocol. Maybe with an enhanced recovery protocol, you're thinking about opioid utilization and wanting to decrease opioid use, time to general diet, early ambulation, the list goes on, and even including patient-reported outcomes. What I would say is we also need to be thinking about these types of implementation outcomes. Was the intervention that we designed acceptable to our care providers on the front lines and to our patients and families? Did we reach the right patients every time? Or did someone slip through the cracks because we didn't know that they were being scheduled for their next surgery? Did we really adopt and adapt the enhanced recovery protocol for our specific patient population, their unique needs, their unique challenges? Fidelity is basically a fancy way of saying that did the intervention get delivered in the way that we intended it to? What were the implementation costs? These things do cost money, as was described in the prompt, right? We need resources. And did we appropriately get those resources in play before we started? And then how do we measure sustainability? The Hawthorne effect is very real. We all know that. As soon as we take our eyes off the prize, we begin to drift back to our habits. So I'm going to give you some real-world examples from the Enrich Us trial. Enrich Us stands for Enhancing Recovery in Children Undergoing Surgery. This is a study that's seen year 4 of 5. We've enrolled 475 patients as of this week in the study. We're hoping to get up to 600, making it one of the largest studies of its kind ever done in pediatric surgery. It equally looks at clinical outcomes like length of stay, as it does the implementation outcomes I've discussed. And we do that with in-depth qualitative interviews with sites to really understand what's happening on the front lines. So let's take a couple of pearls, of tenets, of elements of enhanced recovery and explore them. Let's start with decreasing perioperative fasting. This is a very important aspect of enhanced recovery protocols and something that we struggle with. So one way to handle this is to really think about what we want to make a part of our change with our enhanced recovery protocol. We want to decrease preoperative fasting and allow folks to have carbohydrate drinks up until an hour or two before their surgery, before their induction of anesthesia. So there's a way that we can do this vertically integrating it for every enhanced recovery protocol. We can do this for our pectus patients. We can do this for our GI surgery patients. We can recreate it and do it again for our bladder exstrophy patients. We can do it for our spine patients, et cetera. And every time it's like we're reinventing the wheel. And yet, the night before surgery, they get a phone call that says nothing to eat or drink after midnight, and we're totally derailed, right? So a better way of approaching this is a system-level horizontal integration. And what we did at Lurie Children's this past year was enact a 1-hour protocol for all patients undergoing surgery at all of our sites that they can have clear liquids up until an hour before surgery induction. What that means is now everyone is getting essentially enhanced recovery in this regard, and it's our new standard of care. Now, what that means is we have to have buy-in, and there was a wonderful session at last year's APSA that talked about the changing rules and paradigms for NPO. And 1 hour is a little bit more robust. I think most institutions are okay with 2 hours, but there are several pediatric centers across the United States as well as in Europe that are doing 1 hour, and that's what we chose to adopt. The next thing we did was we wanted to be able to document when these patients had their clear liquids. Did they actually drink it on their way into the hospital or not? And so we documented that in our EMR as part of the nurse intake in the preoperative holding area, and now we have that radial button that's either checked or not, and we can actually document our adherence to that element. Those are implementation outcomes. This is a Colon Man, meet Colon Man. He's from Le Bonheur Children's, one of our 18 sites in the Enrich Us study. Colon Man was developed in conjunction with the research team, the clinical team, as well as child life experts. And what you do is you start in the cecum, I guess, with the evening after surgery, and you work your way through the colon and all the things in the right colon are all the things you're supposed to do on that night. And then you get to the hepatic flexure and you move across the transverse colon and you start doing those elements and meeting those metrics, which include early ambulation and advancing your diet and decreasing your opioids and all that stuff. And eventually you're discharged, no pun intended, right? So this does take some investment of time and energy and resources, but it includes bringing the key stakeholders to the table, the patients, the families, all the key stakeholders were able to give input about this. And it enhances communication. When Colon Man is posted in the room, there is no question about whether or not you're allowed to advance your diet. There is no question about what the first line or second line pain medication should be. And the discharge criteria are clear as day so that everyone knows how to get these patients home safely and promptly. All right, another site had some limited resources for early ambulation. They wanted their patients up and moving, and there were a couple of challenges, real-world challenges. Maybe there's a shortage of physical therapists that were able to visit the patients on post-op day 1. It's challenging to document ambulation in most EMRs, right? There's not a spot in the EMR in the flow sheet where you say how far the patient walked and did they walk or not, and things along those lines. And so they had a wonderful child life team at Memorial Hermann down in Houston, and they wanted to incorporate these awesome extra team members, which were the dogs. And there wasn't a single kid that they would approach and say, would you go for a walk? And they're like, no, I don't want to walk, it hurts too much, et cetera, whatever. And they say, oh, but you get to walk these wonderful dogs. And all of a sudden the kids are up and walking, right, in the hallway. And what's beautiful about this is that this team, this child life team, was able then to document that the patients walked the dog. And they would document that they walked the dog around the floor, which was, X number of feet or whatnot. And so then you once again are able to codify this important element for enhanced recovery without necessarily having a tremendous amount of resources. The last thing I'll talk about is celebrating your efforts, right? A lot of these quality improvement efforts, as they relate to enhanced recovery, antibiotic stewardship, or anything else you've heard in this session or other sessions, they really do involve multidisciplinary teams that are volunteering their time oftentimes to help move the needle for these important outcomes and these important efforts. We need leadership support, and Larry's going to talk a little bit about that here in just a moment. But we also have to keep our stakeholders engaged. This is a wonderful event that was held at Cohen Children's after their year of going through implementing the enhanced recovery protocol at their institution. They brought their team together. They had T-shirts made that said "Get Better Faster" or something along those lines on the front, and enhanced recovery protocols on the back. They had balloons, and they did this in the lobby, and they had key team members present throughout the day to celebrate the institution of this protocol at their institution. And really their leadership showed up, their C-suite showed up, and it's something that they are scaling to broader and broader populations of patients. And so it's really important to celebrate. So in conclusion, I really think that we have to think beyond the clinical effectiveness measures, which are, once again, most important to us and come easy to us. But we have to think about things like implementation outcomes that are a little bit harder to measure, require a little bit more digging. These barriers to implementation are very real, and they can derail our efforts. We have to be creative with our solutions, which really includes tilling the soil, getting the ground ready for these QI projects to take root, with the pre-implementation things we've talked about. Iterative PDSA cycles, oftentimes the first 2 or 3 cycles are going to fail. We know that. Just having that resilience and resolve is important. And then leveraging the lessons from our peers through learning collaboratives. The QSC toolkit has been talked about a lot here, but also just taking some of the little pearls that you hear from your peers and colleagues like I've shared with you today back home. And hopefully with that in place, you'll be more successful. Happy to talk more towards the end.
Thank you. Thanks, everyone. We don't have much time. I'd like to invite Dr. Moss to come up here. Dr. Moss, we want to hear from you as well, because we all are dying sometimes to approach our C-suite executives in terms of what do we do to align our QI work with the institutional priorities, right? How do we increase the visibility of our team, of our interventions, of our early wins, so that executives can be aware of what's happening, and what are good strategies that we can do to secure buy-in of leadership, financial support, as was discussed in the earlier case study, and how do you measure success of our interventions and return on investment? We really don't have time much, but I really would like you to come and share with us. Thank you all.
Thanks, Monica. Good afternoon, everybody. I'm looking at the clock, so I'll be brief, no matter how long it takes. And I don't have slides, so feel free to. It'd be great if you could turn up the lights. Before I jump into your questions, Monica, I've known some of these guys for a long time, and it's really impressive to see the dedication and commitment and perseverance and the difference that can be made over the course of a career. So I have a lot of admiration for the opportunity for everything these guys have achieved, and for the opportunity to be up here and talk to you a little bit. So if you don't want to hear everything I have to say, or you want to be first in line at the bar, here's the 3 things you got to remember. Just do the right thing, play well with others, be nice. And if it sounds like what they told you in kindergarten, it is, and it's going to serve you pretty well the rest of your life. So let's unpack those a little bit. With respect to do the right thing, let me let you in on a little secret of being a CEO, so you can kind of lean in here so those guys in the hall don't hear this. But when you become a CEO, they don't take you in a room and teach you a secret handshake. They don't implant a chip in your brain that changes your values. Sun still comes up yellow, sky still blue. It's the same stuff. And we all went into pediatric surgery because we cared about making the lives of children better. Those guys in the C-suite in your hospital, they're the same. And whether they're physicians or not, they're the same. And they ultimately have the same focus and the same goals. So, we can tend to say, well, I need to get in the head of my executives to figure out what they're going to support. I need to figure out what they want. We all want the same thing, which is better patient care. And with respect to any quality improvement effort that's meaningful and makes a real difference to patients, it's going to be a priority. I mean, show me a hospital that doesn't have quality of care and optimizing quality of care in their strategic plan, and I'll show you one that's going to go out of business pretty soon. So it's not a matter of figuring out some arcane priority. It's a matter of figuring out what's actually meaningful to the largest number of patients that's going to make a difference in the outcome and quality of care. And that tends to take priority over the financial issues, because better care is always better financially, and so the focus, especially from clinicians, needs to be on why is this better care, and not so much showing up with a spreadsheet on how many pennies it's going to save. With respect to playing well with others, I'll tell you a story from my past. A long time ago now, I was a brand new fellowship program director, and I got to go to the program directors meeting for the very first time. And the topic on the agenda was, should we continue to have closed surgical units and not allow the pediatric ICU people to touch our patients or have anything to do with them? And I was a new guy in the room, so I spoke up first and said, no, of course we need to involve, they got ideas too, of course we need to work together. And man, was I a turd in a swimming pool at that session, and did not go over well, and laughed out of the room. And as I look back on that, my point is not I was right and they were wrong. That's not why I told you that story. My point is being curious is always, always, always better than being judgmental. And you will be looked at with respect to the design and the execution of your project, how thoughtful you were in terms of seeking broad input and perspectives other than only the surgeon's perspective. And that's a marker for somebody that's going to be successful and knows what they're doing. And frankly, if I look at what Sean and Mehul and Barron have done throughout their careers, it's exactly that. And that's why they're sitting up here, because they have been successful in those efforts. Now, finally, be nice. In my role, I have the opportunity to hire a lot of leaders, and it's not that hard to find people that are really smart, and it's not that hard to find people that are analytical and have some really thoughtful ideas. It's a lot harder to find people who are nice and people who others really, really want to work with. If you go to the most basics of human psychology, and well, how do we make decisions? Well, we take in all kinds of data and we analyze it, and we make this, we look at all that stuff with the left side of our brain, but when it comes to ultimately making a decision, we do it with the right side of our brain, and it's ultimately an emotional decision. Does this feel right? And it's a lot more likely that a good person with a bad idea is going to carry the day over a bad person with a good idea. So ultimately what we want is a good person with a good idea that really move things forward. But if you want to lead these efforts, you've got to be the kind of person that people want to be around and want to work with and want to be part of the team. So the last thing I'll say is a couple words about how hard this work is and how how much perseverance it takes to really be effective. One of my favorite quotes from literature, there's a lot of debate over who the author is, so I won't attribute it to somebody specific, but it's a well-known author that said, "I hate writing, but I love having written," which, if you really think about that, there's a lot of parallels to quality improvement. I hate doing quality improvement work. It's hard and it's messy and it's painful and it's pushing stones uphill, but I love seeing better quality of care for kids. And the people that tend to carry the day are the people that realize that and realize how hard it is and are willing to put in the real work. And typically, asking for a lot of resources can be code for, I don't really want to do the work, so I want you to give me a bunch of money so I can have other people do the work, and they're never going to do it as well as you could do it anyway. And so willingness to do the work, that is hard, and that your C-suite knows is hard, is going to get you a long way. So I really appreciate the opportunity to talk to you. I really have a lot of admiration for the work that's going on. I was on the APSA Quality and Safety Committee in the past, and it's really impressive how far the committee's come and how the contributions to pediatric surgery. So thank you again for the privilege of being here, and I'll turn it back over to Monica for questions.
Thank you. Thank you very much, everyone, especially our panelists. Is there any questions? Would you guys come up to the mic for any comments?
I defend myself from getting up to the mic all the time. You guys should complain, except I know the entire program so well. I know every question I already had before today. So this is my question for Mehul. The implementation science studies seem very, very cool. That's a direction. I love how it's flipped on its head on how you look at it with behavioral, through behavioral lens. And it's a lot of what we want to do in Phoenix with multidisciplinary team study. What are the funding resources for implementation science? It is not clear that it's NIH, PCORI. Do you have any clues on funding resources we should be looking at for that work? Thank you. Thanks so much.
Oh, testing. Yeah, okay, it's working. So there's actually, I would say, a fairly reasonable amount of extramural funding to support work that's designed with implementation science in mind. And I think that there's a couple of very obvious ones, which are there are maybe two ways of implementing, and we're not sure which way is better. And so we're going to do a study or a trial where we test one implementation strategy versus another. There's another way of looking at it, which is through the AHRQ or through other funding agencies that normally fund quality improvement work, is to use a theoretical framework that's well founded in the implementation sciences. There's a ton of frameworks out there, and I'm happy to help you find the one that would fit your study the best. But ultimately, using that framework adds a tremendous amount of methodologic rigor to your approach. And so even though the study itself is not to compare two implementation strategies, the use of an implementation framework in your intervention will really elevate the game and I think make it a much more competitive application for funding. There are people, including many centers and institutions, who have built out dissemination and implementation cores or institutes or teams, and I would highly recommend identifying some of those experts to be co-investigators or collaborators on your studies, because once again, we are surgeons. We see it from the clinical perspective, and oftentimes we have blind spots to many of the challenges of implementation that these folks can really illuminate and partner with you on, and I think they're just tremendous assets.
Okay. Well, thank you, everyone. I don't think there's any other questions that I can tell, and we're out of town. Yes, everyone return here at 4:40 for the next session. Thank you for your attention.